I'm Satya Krishnasamy. I think most of you all here know me. And I do this talk with trepidation. I haven't done a talk on Cushing's, full disclosure, in the last 10 years. However, in the last year, being a part of the neuroendocrine division and with some of the tutelage with Dr. Winters has taught me over the years, I hope to be able to share some of the information that I learned in the last few months taking care of these patients. There's a lot you learn from the patients as much as you teach them. So it's a very important disease. And it's also a very humbling experience because if anybody says Cushing's is easy, like one of the national clinicians says, they perhaps haven't seen enough of Cushing's if they say that. So, and that's always going to be true. So with that, I'll get started. So I always, as you all know, have dedicate my lecture to somebody or groups, and of course it's the patients and their caregivers who, with Cushing's, it's a lifelong struggle and lifelong disease. And of course, any talk about Cushing's would not be complete without paying tribute to the father of modern neurosurgery, Dr. Harvey Cushing's here. And there's a recent biography about him, very interesting. Cushing's, Dr. Cushing, I think father, doctor, and surgeon. So I wrote 2 extracts about it, and it was very interesting. So objectives, I think everybody has a copy of this to discuss a case. And of course, I wait to hear input from everyone else. And to summarize the diagnostic evaluation, recognize some of the caveats, limitations, and also discuss available therapeutic options, to discuss the options and to summarize prognostic factors. I do have to also speak a few words about the genetics of Cushing's, which is also very interesting. So we start with the case. 27-year-old patient who was seen in the emergency room few years ago for after altercation and had an incidental CT done, and which showed a mass, so underwent an MRI, and there was a sellar mass, which was a pretty significant macroadenoma. And upon further questioning, they did admit that 100-pound weight gain over the last 2-3 years, fatigue, anxiety, insomnia, and also purple striae, and which were pretty impressive. The usual more than 1 inch, and lower abdomen, and all the way up to the axillae. And random cortisol level done was 17.3 micrograms, and low dose 1 milligram. It's actually not a LDDC, it's overnight dexamethasone suppression test, was 7.1 micrograms. And ACTH levels were there, but with the switch of EMR, somehow I couldn't track it all the way back in the last few days. And 24-hour UFC was reported as normal. Actually, patient was seen by Dr. Winters, then Dr. Villafote, and finally I have been following him now. So following them now. So this is the CT, the MRI T1 images. As you can see, the very impressive adenoma with suppressor extension, and it also goes into the sphenoid sinuses. And the patient underwent an EEA, which is endonasal adenoma resection, and at 2 days after the surgery, the cortisol level fell less than 4 micrograms per deciliter. And he did have some symptom relief over time, and this is the pathology report. I don't have the PATH slides. Unfortunately, I didn't get time to get them to right away. So it was clearly a ACTH secreting adenoma, positive ACTH. TPIT was diffusely positive. Again, these have gone into an older medical record, so retrieving the actual PIT1 follow-up data is still pending. I haven't been able to get that. So that was the information. 8 months down the road, his cortisol level is 5.6. 10 months after that, after the surgery, he underwent, due to symptoms, 1 milligram dex suppression overnight dex suppression test, which was 1.4 at that time, so less than 1.8. 18 months post-op, his random cortisol level 10.2. 20 months post-op, he underwent another 1 milligram dex suppression, and that was 4.2 micrograms, clearly much higher than the 10-month follow-up test. And at that time, his ACTH levels 82 picograms per ml. And he did start complaining about some weight gain, feeling much worse, difficulty concentrating in school, and also a multitude of other symptoms, and worsening easy bruising also at that time. So, and based on the data, it was determined, and the MRI, as you can see here, it was determined that he perhaps had persistent Cushing's, and he underwent a second surgery about 22 months after the first one. And the pre-op levels of ACTH at that time, 236, post-op 66, which was 10 days later. And he had had multiple sequential levels during the course of that time on the 10 days, and also had had multiple cortisol levels, which neurosurgery, sometimes they follow the every 6-hour cortisol lab draw, and anyway, it fluctuated anywhere between 40 to 7. So we'll stop right there and come back to him a bit later. And I'll go on and discuss a little bit about the Cushing's. It's the most common disease. Cushing's disease is the most common cause of endogenous hypercortisolism, and the prevalence is about 40 cases per million. When you look at a hypercortisol patients, about over 80% of them are usually Cushing's disease. Like I said, it's underdiagnosed many times because of some of the milder cases, cyclical Cushing's, and prevalence is probably much higher than what it's reported, which is 40 cases per million. Certainly, it's much higher than that. And of course, increased mortality, increased morbidity, and also it's even though they're much younger as a group, the Cushing's patients, the mortality is much higher. And of course, the death rate, if untreated or undiagnosed, 50% at 5 years, which is pretty serious. And it's a life-threatening emergency, so the minute it's suspected, it needs to be intervened right away. And despite all the advent of anti-cortisol drugs that we have available, which I'll be talking about a little bit, the surgery by a good surgeon remains to be the top choice at this time. And the comorbidities do persist for a long time after biochemical remission also, so it's very important to educate the patient. So early treatment is important. And also the long-term morbidity and mortality is associated with the duration of exposure to the cortisol excess. So earlier the normalization, the better the patient is. And it's, of course, an interdisciplinary group of providers, of physicians that are required, and individualized approach for each patient. We are fortunate to have that thanks to Dr. Winters, who set up the neuroendocrine unit. So, and also unique needs such as pregnancy, which by itself is a 1-hour topic, is important. And also lifelong monitoring, early on anywhere between 2 to 6 months, and as frequently as 2 months, or as sometimes yearly as it spaces out. And we've had patients who have had recurrence as late as 25 years later, so that's very important. While normalization of the urinary free cortisol using drug treatment may not be synonymous with restoration of the normal function of the pituitary axis, and we struggle with that. where different tests may not, there's a lot of discordance between test results versus clinical normalization, clinical remission, and biochemical remission. So, and as I explained earlier, it is the most common reason for hypercortisolism. It is persistent stimulation of ACTH release and absence of the negative feedback from the cortisol, as opposed to the syndrome where there's autonomous cortisol production, which is independent of ACTH. The symptoms, which most of us here in the audience are familiar with, moon facies and facial plethora. And let me tell you, there's so many other patients who present this way, and I do the test and I don't find it. And of course, there are some subtle patients with some subtle symptoms, such as the one that Dr. Villaforte presented a few talks ago, where it could be very mild, or MACE, which is mild autonomous cortisol excess, which can present, and you think they have metabolic syndrome and ends up being Cushing. So in one of the studies, it showed about 7% of patients who present with perhaps some of the metabolic syndrome traits could actually be hypercortisolism, either syndrome or disease. So it's important to keep that in mind every time we see uncontrolled diabetic or somebody with rapid weight gain or any of the other attributes that you see in these patients. And weight gain and also bone loss, decreased subcutaneous and peripheral adiposity. Sometimes they have emotional lability with that, and increased visceral and retroperitoneal adiposity, and core muscle weakness and sarcopenia, described as apple on sticks, which is a pretty classic example, but by then it's too far ahead and we want to catch them before that. Oligomenorrhea or any other menstrual irregularities can be possible, and striae, easy bruising, acne and hirsutism, peripheral edema, epidermal thickening, and not to forget a very powerful factor, which is the neuropsych symptoms, impaired quality of life, and also low bone mass. So anybody whom we see with unexplained osteoporosis and also fractures or kyphosis, we have to always have a high degree of suspicion for hypercortisolism. So what is the recurrence percent? About 14%, anywhere 5% to 21% between 3 months to 158 months. The data varies depending on the studies that we look at. So 50% of the recurrence occurs within the first 15 to 50 months post-op, just like our patient that we have just presented. And also the criteria differs, the clinical criteria versus biochemical criteria, and how it was measured. So some of the questions when you look at the studies that were done looking at recurrence and persistence, look at how was remission defined? Was there a need for glucocorticoid replacement? What was measured? Was it cortisol, serum, urine cortisol, or was it a low-dose DEX suppression test? When was it done? Was the test done right post-op, or was it a few months later, a few weeks later? And also, were there empirical steroids given in some patients post-operatively? Routinely, they get steroids independent of the cortisol criteria, and also where patients on ketoconazole. I remember a few years ago where we had a patient, we had to start them on some steroidogenesis inhibitor drugs before even going to surgery because of the intensity of their hypercortisolism. And also, how long were the patients followed post-operatively? So the usual definition of recurrence and persistence is post-surgery, post-op surgery cortisol, which is less than 1.8 micrograms per deciliter. In our patient, I believe 4 days later, it was 4 mics, but then in the office, he did suppress very well to 1.4. And also, if somebody required a glucocorticoid replacement, not empirical glucocorticoids, but definitely had symptoms of glucocorticoid deficiency and required replacement. And also, months to years of remission followed by recurrence later as opposed to persistent. So there's a difference between recurrence and persistent. And the remission criteria certainly varied based on studies, as I would share with you. There was no standardized way of measuring. There's about only hundreds of studies that they are this is just a sample of the studies. And this is a summary of some of the studies. And the top was 5 years over 5 years of follow-up. And the studies in the bottom were less than 5 years of follow-up. And of course, the remission rates, the number of patients, and these studies are all patients where the N was over 100, and they looked at recurrence and persistence, both of the criteria. And each study used different testing protocols, biochemical protocols. Some would use the DEX suppression, some would be UFC, and some, I think I even saw some late night salivary cortisol. So it was very different. And so there's no harmonization of criteria for remission, as you can see that. So what are some of the predictors for remission? How can we say pre-op which patient will have a certain years of or months of remission? Well, if there is a tumor identifiable like our patient did, prior to surgery, then it does predict remission. And certainly those patients who there was no tumor identified and had to go the IPSS route, it is the course is a little bit different. If there's no invasion into sinus cavernosus by the adenoma, which our patient had sphenoid sinus invasion at that time, and low post-op cortisol levels, and they talk about less than 2 micrograms, below normal ranges and not measurable. Low cortisol levels 6 to 12 weeks after surgery, and long-term steroid replacement over 1 year, or long-term low cortisol levels over 1 year. 1 year is the time that they use, and low ACTH levels, 13 picograms per ml or less, and post-op ACTH of less than 3.3, and histologic confirmation of adenoma, which we have, and lower DHEA levels pre-surgery and lower ACTH levels pre-surgery, such as our patient with the second surgery, it was 200, but here 71 is the preferred cutoff that they use. And a significant decrease in weight post-surgery was predictive of a longer remission. And of course, experience of the neuroendocrine or the pituitary center is also very important. Age, so younger age, more the recurrence, and no USP8 mutant corticotroph tumor, which is something I'll talk a little bit more because I found it very interesting. Shorter time to recovery from post-op adrenal insufficiency, and post-op cortisol response to desmopressin. I'll go over that in a few minutes. Low cortisol and ACTH peak after desmopressin, and response to desmopressin after 6 months. So post-op and after 6 months, DDAVP stimulated ACTH cortisol levels. And post-surgery 11 deox less than 150 nanomoles after meteropone test, which is not a standard test that we use. And 48-hour DEX suppression test of cortisol level less than 49 nanomoles was also predictive. And these are based on the different studies that are on the right side of the screen. And so when there's a suspicion of recurrence, or in this case persistence, what is some of the options available? So patients have worsening symptoms just like our patient did. So perhaps one option is to collect late night salivary cortisol 2 to 3 times, repeated. Usually late night salivary cortisol, it's recommended that you repeat it more than 1 time. And if it's high normal, like I mentioned, even 2 to 3 times, and sometimes they say you can even do it daytime. And overnight DEX suppression test, collect UFC at least twice or more, that is 24-hour urinary free cortisol. And we'll go over some of the caveats with each of these testing. And repeat test if there's a discordant result. And also additional testing such as the low-dose dexamethasone test, CRH or the DDAVP, and also evidence of MRI, just like our patient did, also requires further investigation. So what are some of the limitations, or what are some of the different aspects of these tests that we need to know? The LNSC, which is the late night salivary cortisol, sampling collection is very important. Patient has to know how to chew on it, drool on the kit, and collect it properly. And also, there are certain interfering substances. And patients who are on steroids, this can interfere certainly at that time. And also, if they are smokers and if they're on licorice, or if there's any leaking of blood when they aggressively brush their teeth or anything, that also interferes. And shift workers, it's not reliable. If it's a third shift worker, late night is not good. Perhaps it should be the next day, or they should, at least for 3 days, change to a regular kind of circadian rhythm and then get the test done. Smoking metabolic syndrome can increase the risk of false positive test. And definitely it's preferred to the ease for testing, just because you don't have to collect urine for 24 hours or don't have to come back in the morning, 8 a.m. for a test, such as the 1 milligram dex. And it is very apt for cyclical Cushing's, which, you could repeat it over a course of time, and you may get a higher kind of chance of results. The overnight dexamethasone test, of course, this again has its own issues. There's variable absorption and metabolism of the dexamethasone, and any drug which accelerates metabolism or impairs metabolism, the older anti-epileptics come to mind. So the recommendation is to measure dex levels and maybe even ACTH levels along with the cortisol levels when you do it in the morning. And of course, any drugs that interfere with the cortisol binding globulin, such as birth control pills, any estrogen, will certainly affect it. And also, it can be normal in cyclical Cushing's, depending on the time, the cycle of the Cushing's. So, and also, some of the other aspects of the late night salivary cortisol in a single center study. The recurrence was predicted when they looked at 164 patients. It did predict a recurrence at about 53 months follow-up, but within the first 3 months, the late night salivary cortisol was not a very good way of measuring. The sensitivity was 75%, specificity is 95%. And it is recommended to use the radioimmunoassay of the salivary cortisol as opposed to the LCMS, mainly because of the accuracy. However, if the patient is on dermal or cutaneous or topical hydrocortisone, LCMS is actually much better or more accurate. And as I mentioned earlier, age, time of the day, tobacco, metabolic syndrome, they all do limit that. And the 1 milligram dex, like I mentioned earlier, depending on medications that may interfere, there may be issues. The criteria is less than 1.8 micrograms, and dex level and ACTH level are helpful. And the LDDST, which is low dose dex suppression test, which is 0.5 milligram of dexamethasone every 6 hours for 48 hours, and then performing the cortisol level, is also an option. And also a LDDST CRH, where you complete the 2 days of test and then IV CRH and then measure the levels, is another option. However, depending upon, for recurrence, the LDDST is not as accurate as 1 milligram is. So those are the different caveats. Now, urinary free cortisol, which is very commonly used for follow-up and to monitor recurrence, and also used for pharmacotherapy, also to follow patients to see if they're responding to pharmacotherapy. So again, sample collection is a challenge. Depending on patient, can they remember to collect exactly for 24 hours? And if they drank a lot of fluid that day, would that be a little bit different? And again, one sample may not be accurate, may need multiple samples. And For example, this patient, when the first time he was screened, the note said his UFC was actually within normal limits, while he had such a large tumor producing ACTH. So sometimes it may not correlate with the other tests or the clinical disease. And again, it can be normal in cyclical Cushing's disease. And the other option is immediate postoperative morning serum cortisol measurement, which is sometimes a good criteria to look at. But this again could be affected by steroids that we use, which may suppress the ACTH secreting cells. And also, if they're already on medication, pharmacotherapy, like I mentioned, our earlier patient who was on ketoconazole, it could be a problem. And again, with cyclical Cushing's, there's no perfect testing, and it may be limiting that factor. And here, liquid chromatography mass spec is much better than immunoassay for urinary free cortisol. And it is said, based on longitudinal studies and also the 2015, I think the Cushing's update by Endocrine Society, for early detection, sometimes 1 milligram dex and the late night salivary cortisol are better. And over time, longitudinally, after a few months, the UFC may be more accurate. And of course, sometimes there's a lot of intra-patient variability. The collection may vary depending upon what it is. So, and the one other test which more recently has become more popular, which I haven't personally done this before, is the DDAVP stimulation test, which has been used for two reasons: for early detection of recurrence, and also initial evaluation of patients. When the screening has been done, when you want to distinguish a patient whether they have ectopic versus pituitary Cushing's, this has been very helpful. 10 microgram of intravenous DDAVP is given, and sequential ACTH and cortisol are measured. So it's abnormal if there's an increase of ACTH of over 25 picograms per ml from baseline, or if it peaks at over 70. And also if the cortisol increases by 5 or it peaks at 18, then it's abnormal. And in normal patients, there's no response, and actually sometimes there's a decline. So it has been a test that's been used immediate post-op and sometimes 6 months post-op to look at recurrence, and has had a pretty good accuracy. And some of the other tests that have been used in some of the other studies could be the perioperative ACTH levels, which we saw in our patient. They had serial ACTH levels by the neurosurgery team, and also serum cortisol level in the first 14 days post-operatively. Post-op ACTH levels first 14 days, which we had in this patient. We have serial levels being measured, and every 6 hours for 3 days. That is the other option. And also a CRH test about 10 days post-op. Those are some of the other tests that is done. So that is about the testing and limitations, and recognizing the caveats, and knowing that there's a little bit of a discordance, and many times if there's a clinical suspicion, we have to repeat the test or try a different test, but not give up. So coming to some of the mechanisms of pituitary tumorigenesis, I just wanted to segue to this topic mainly because of the USP8. As most of us know here, to form pituitary hyperplasia or tumor production is based on growth factors, mutations, and epigenetics, macroadenoma, and many times is monoclonal expansion, and rare mutations can cause carcinoma also. These are some of the studies that have been done in the last 10 to 15 years. So it's called the PITNET data, which is pituitary neuroendocrine tumor data. And the top is looking at the different methodologies, microRNA, transcription, factors, DNA, and then different studies, linkage studies, and the different mutations that have been looked at over the last several years, and very interesting. Each one of them has very unique, interesting things, but we'll mostly focus on USP8 PITNET. And before I go to that, I did want to summarize the different genetic mutations that is seen with Cushing's. This is something the fellows may find very interesting. I'm not going to go over each one of them, but these are different mutations in different adenomas, such as the growth, acromegaly or somatotroph adenoma, lactotroph, corticotroph, thyrotroph, gonadotroph, and null cell, which is non-secretory. The red is the different germline mutations. The green is the somatic. And this area here is the transcription factors in the nucleus, and the white area is actually the transcription regulation, and the blue is where there's a loss of heterozygosity, the chromosome loss. So I'll just mostly focus on the corticotroph adenoma. There's been several of these mutations, and most of them are somatic, not germline. The germline is in prolactinoma, MEN1, and a few years ago, Dr. Winters had invited Larry Froman. It was a great guy who I think received an award this year in Endocrine Society. The FIPA, which is the familial, familial pituitary adenoma, and AIP mutation. That was his area of research by Dr. Froman, and that is something you see in acromegaly. In fact, I saw the twins in Cook County Hospital when I was in training in Chicago at Rush. So coming back to the corticotroph adenoma, USP48, NR3C1, and USP8 is related to the epidermal growth factor regulation. So that is something very important. And these are the different transcription factors and the hormones that have been released. So when you look at Cushing's syndrome and disease, certainly, like I mentioned earlier, the different ones, and PTTG we have heard in this room before several times with researchers from our from oncology and our endocrine group. So Dr. Villaforte did go over the adrenal mutations with a very nice summary, so we won't go into that today, but certainly there are very interesting mutations there also. These are the summary of the different ones. In fact, I found this very interesting. It's called the Brahma mutation. It's a chromatin remodeling, and it facilitates GR response. And there's another one, which is the sonic hedgehog mutation also. So those are the two that kind of come to me. So the genetics of Cushing's disease, it is very interesting. Not so common in Carney complex or McCune-Albright or MEN or MEN2B, MEN4. FIPA, there's 4 cases. And tuberous sclerosis. What it is commonly seen is in DICER1, which is mostly an infant pediatric syndrome. I've never seen one with multiple pluripotent neoplasms, including renal and lung and multiple other neoplasms. There is a higher prevalence in this disease of Cushing's, so that's something interesting. So the USP8 or the ubiquitin specific protease 8 is something which has been shown in the last 5 years to be frequently mutated in adenomas causing Cushing's disease. It is a rescue protein in the ubiquitation pathway, and it rescues the ligand-activated receptors from lysosomal degradation. And in a way, it de-ubiquitates EGF. It protects EGF, or epidermal growth factor, which in turn acts as a CRH, like CRH, and the USP8 potentiates the EGF-mediated ACTH secretion in these corticotroph tumors, which is very interesting. And in a study with 48 patients, patients. The study was actually more than 48 patients, but 48 of them, that is 36%, had Cushing's disease. And interestingly, it's seen a lot more in adults and a lot more in women than men. And this is one other study, I won't go into too much detail, where the remission, it does predict remission. When there's a mutation, compared to the wild type, the mutated tumors, there's a lower remission, chance. So that is something important to remember. So when you look at predictors, if there's a USP8 mutation, then the remission is lower. So that is about the testing and the genetics of the Cushing's disease. And now we'll go into a few treatment options. Obviously, when there's persistence or recurrence, the interdisciplinary group discussion with tumor board, such as our patient, there was presented at the tumor board and discussed. And then the treatment is planned, the pathway to different options to remission. And definitely with very good surgeons, the second TSS surgery is actually the best option, especially in a younger patient. 38 to 90% likelihood of hypopit, which I did fail to mention. Our patient, after the first surgery, had to be placed on DDAVP and Synthroid, and also was on androgen replacement. So, and radiation is the other option. Medical therapy and bilateral adrenalectomy is 100% success. Of course, that is kind of the last resort to most of our patients because of the lifelong glucocorticoid replacement and concerns for adrenal crisis. So what are the different options and what are the concerns with that? Like I mentioned earlier, experienced surgery is the best option. Of course, hypopituitarism in most patients, and any risk that goes with surgery. We had one patient who underwent surgery. He had a PE post-op, so that's something to remember. A radiation treatment could be done for those patients who are not suitable, or post-op. And recurrence is possible. And again, here, hypopit over a period of time. And this also requires several treatment sessions. Medical therapy could be used as a bridge therapy or acutely ill patients to prevent Cushing's crisis. It could be used. And again, side effects, high cost. Cost is a big issue, and longitudinal follow-up. And success rate is about 25 to 60%. Radiation is 40 to 70%. Adrenalectomy is definitive 100%, but one we would try to avoid because of Nelson's tumor, which is pituitary hyperplasia, and Addison's crisis. Those are some of the concerns. So medications, we have several options available. The most, starting from the top, pituitary-directed somatostatin analogs, pasireotide, dopamine agonist, cabergoline, adrenal-directed drugs, steroidogenesis inhibitors such as ketoconazole, meteropone, and mitotane, and glucocorticoid receptor-directed drugs such as mifeprostone is another choice. And of course, more recently, there's one other drug which I'll just spend a couple of minutes on that. These are the different phases the drugs are in. Phase 3, pasireotide, LAR, meteropone, osilodrostat, which there was a LINK-3 study last year, and this year there's a LINK-4, which is the further follow-up study, and certain other agents that are available. So starting with the steroidogenesis inhibitor ketoconazole, the dose and effectiveness, it normalizes 24-hour urinary free cortisol, normalizes about 50% of the cases. Escape may occur. And of course, GI side effects, hepatotoxicity is a big concern, and frequent monitoring is quite important, but it's cheaper compared to any other drug that we have. Meteropone, 250 to 1,000 milligrams 4 times a day. Serum about 76% effective, and normalization serum cortisol control is 76%, but UFC normalization is 43%. And even here, escape may occur. And none of these drugs come without side effects: hirsutism, acne, hypertension, edema, hypokalemia are some of the side effects. And during pregnancy, it's the preferred drug. Mitotane and 85% 24-hour UFC normalization. Again, multiple side effects: hepatic, metabolic, neurologic, hematologic. It is abortifacient and teratogenic, delayed onset, and primarily used in adrenocortical carcinoma. Etomidate, and highly effective in short term. This is a drug which is used for induction in anesthesia, which is now used as an infusion in acute Cushing's crisis in patients that are admitted and have, are pretty critically ill. And of course, sedation, nausea, vomiting, and it's like I mentioned earlier, it's for critically ill patients, and it requires careful monitoring also. Cabergoline, 0.5 to 7 milligrams PO weekly, much higher doses than what we use for prolactinoma, 40% UFC normalization. And of course, this also has its own side effects, and long-term valvulopathy is a concern. And like I mentioned, higher doses than what is required for prolactinomas. Pasireotide is 24-hour UFC normalization is 26%. And hypoadrenalism, hyperglycemia, and QT interval prolongation need to be monitored. And there is a LAR also. And it's almost similar again with pasireotide, which you will get in the boards, is about the blood sugars for blood sugar monitoring. Temozolomide, I don't have much experience with that. It's administered by a neuro-oncologist, and these are for aggressive tumors which have no other intervention. Other interventions have failed. 80% of the cases may go into response, maybe responding. So. And let's see. Oh, that's the wrong one. Mifeprostone, which it's the glucocorticoid receptor antagonist, which improvement in hyperglycemia. This is Korlym, which many of you may be familiar. We have used it in a couple of patients with adrenocortical cancer. Their concerns is endometrial thickening, bleeding, elevated TSH. We have to track many of their hormones in these patients over time. And I think I mentioned already it's abortifacient. So this novel agent is, again, focused on the steroidogenesis pathway. It's 11-beta hydroxylase antagonist. It's osilodrostat, and it's a potent oral inhibitor of the 11-beta hydroxylase. I just wanted to, I think Malika presented this data in her Tuesday conference, but just go over it for a few minutes. The study was published in Lancet last year, and I think there were 3 phases to the study. One was screening at baseline. This could be patients who are not surgery, they're refractory to surgery, or they're refractory to surgical therapy, or not candidates for surgery, or they had recurrence, or also had persistent Cushing's. So they're screened. It's actually a multi-center prospective open label study, but there's one section of it where there's double-blind randomized withdrawal phase after 24 weeks. And then these patients, they were screened at baseline, and they were started on the osilodrostat, and the dose was titrated for a 12-week period up to 30 milligrams from 2 milligrams. And then at study period 2, which is after 12 weeks, looking at who responded well and had normalized levels. They all were continued for the next 12 weeks at a therapeutic dose, individual therapeutic doses. At phase 3, they were divided into 3 groups. So the group that they chose was those patients who from 12 weeks to 24 weeks were on stable doses and didn't require any titration and had very good urinary free cortisol levels. Those patients, based on a a tech response question kind of thing. They were divided into a placebo group and a osilodrastat group, and the rest of them who kept needing titration in the second phase were left on the drug. And then they followed again for 12 weeks, and then after that, all of them went back again into the open label study of the osilodrastat. And this is some of the data. This is at baseline. So each vertical line here is an individual patient, and these are their UFC. So the test or the follow-up lab that was used for biochemical remission was 24-hour urinary free cortisol from baseline to week 24, and this was individuals' highest level at baseline and their response. This is the second group of patients at phase 3, where they divided into placebo and continued on osilodrastat. And some of the patients this was the placebo group, and as you can see, this was their starting UFC at the end of 24 weeks, and this was at 36 weeks. And these are patients who were continued on the osilodrastat for another 12 weeks. They were randomized into two groups. So at week 34, the complete response with the study drug versus placebo was 86% versus about 29% in the placebo group, and with the odds ratio of 13.7. And these are the confidence intervals. At week 24, 72 of the 137 patients maintained a complete response without up titration after week 24, so after week 12. And what were the side effects? Very minimal. Very few patients had to be withdrawn for side effects, actually. And most common side effect was fatigue and nausea and GI side effects. There were some side effects related to blocking the steroid pathway, which was slightly higher deoxycortisol levels. So some of them had those symptoms, and some had adrenal hypocortisolism or adrenal levels, and related, and some side effects related to the adrenal hormone precursor, which I just mentioned. But it was pretty well tolerated compared to the placebo. So what are the different tests that are used during the studies? Most commonly used is the urinary free cortisol. The caveat here again, which may be a board question, is you cannot use UFC for patients who have the glucocorticoid receptor blocker, because that doesn't cause decrease in UFC because it's blocking the receptor. So you may still see, the levels of UFC may be normal. And also the other tests that have been used for follow-up of biochemical remission during pharmacotherapeutics is LNSC, which is late night salivary cortisol, but there's a lot of discordance between LNSC and UFC. And for pituitary targeted drugs such as cabergoline, pasireotide, ACTH has been used, and ACTH has also been used for ketoconazole. So those are some of the things. So, and with the COVID, there's been concerns with Cushing's patient. Of course, those who got COVID-19, there was a nice review last year about COVID-19 and Cushing's. The highest risk was, they went on steroids, of course, glucose control, and the DVT risk of COVID and the kind of the baseline risk of thromboembolism, heightened risk that these patients with Cushing's have, puts them at a much higher risk. And as far as vaccination goes, they should be able to, get their vaccines, and there should not be a concern unless there are some, very few patients. So in summary, long-term remission after surgical treatment of Cushing's disease, biochemical remission is anywhere between 59 to 94%, and we did go through the predictors a little bit. Visualize localization of the adenoma on pre-op images, histologic confirmation, and also post-op low cortisol levels. Those are some of the predictors. And we did go over some of the other predictors, including USP8. And recurrence of the hypercortisolism occurs about 8 to 66% of the cases, and usually more frequently within the first 5 years. And although patients with low intermediate post-op levels are less likely to experience, they still, this can't be reliably excluded. There's been a lot of discordance between the biochemical, clinical, and complete remission. And certainly standardizing this would be very helpful, and monitoring patients, like I said, at frequent intervals would be very helpful. This is a summary of the algorithm of recurrence or anybody with clinical suspicion of recurrence, which some of the signs which we already talked about. And the results are normal depending on the test done, which is LNSC, salivary cortisol 2 to 3 times, DEX suppression, 24-hour UFC, twice or more. The key is repeating them, monitoring, and not giving up after a few tests. And if there's a discordant result and suggestive clinical features, repeat them again. And also imaging, very important, especially with the newer MRIs available. I think it's very easier to find smaller microadenomas. And also, depending on the presence of the, localization may be required, IPSS may be required if there is, tumor cannot be identified. And I had mentioned already about the DDAVP testing, which is a newer novel method that's being used. And also the DEX-CRH test sometimes is used, but the DDAVP seems to be favored. And we did go over the different drugs that are available, and the side effects. Cost is a big issue in many of these patients, so it is very important to remember that. So Cushing's as such is a very endocrine kind of a unique syndrome. Even the diagnosis early on in these patients, where trying to get to the kind of goal of treating and staying in remission. So high clinical suspicion, very important. Spectrum of disease, mild disease. This is not just for recurrence. Anybody with hypercortisolism. MACE, which is mild autonomous cortisol excess. We heard about the adrenal, so-called adrenal goiters or macronodular adrenal hyperplasia, cyclical Cushing's, subclinical hypercortisolism. Those are all challenging, and keeping that in mind and knowing that tests could be equivocal and sometimes elusive, and applicability of the results and methodology, knowing which test and what method to use are very important. And of course, there are no shortcuts in this highway. I finished the talk with this view from, this is called the Hawa Palace, or the Palace of Wind in Jaipur, as India is going through this major crisis with the COVID-19, their fourth wave. I just thought, some of the beautiful architecture, and hopefully things will get better for all of us in the globe. The disease is over when it's over everywhere. That is important to remember. So, and this is the code for today, 1280-947. So I'm open to taking any questions, and thank you all.
This is really common to use more than one medical treatment for Cushing. Let's say a patient has cancer for surgery, or a patient can use like 2 medications, different mechanisms to treat.
Two medications at the same time. So the question is, can 2 different, that's a very good question. 2 different medicines which work in different pathways, can they be used? That is Zach Sibai, our fellow's question. I have not heard or used that before. And like I said, I haven't seen enough patients to say that Cushing's is easier, and I know. But I'll open that to Dr. Winters. I don't know if he is in the talk, or Dr. Mokshagandham. One of them may be able to answer that question. Do you see him?
No, I said stop sharing.
Oh, stop sharing. Okay. All right. to the chat. So let me see. I don't know if you, Dr. Winters, there.
I haven't seen any.
Yes, Sasha, but I didn't really grasp the question.
So the question, hi, Dr. Winters, good to see you.
Thank you.
The question that Zach Sibai, our first-year fellow, or rising second-year fellow, had was, can there be more than one medication pharmacotherapy used at the same time if the patient is not, responding?
Well, I don't know off the top of my head. I don't know any studies showing that, but certainly it sounds sensible. If one medication is not effective, you could try another. I mean, in a young man such as your patient, you always have to think about costs lifelong, and
that's right.
Perhaps that's one consideration when you start to bundle that. I gathered Dr. Williams decided that a second operation made the most sense because, number one, he had a demonstrable tumor, and number two, he was already hypopit. So other than a disaster, which is not likely with a skilled surgeon.
Exactly. Yeah, I think those were the two main reasons.
Most sensible. And then you always have, sort of focused radiation is an alternative treatment for a pituitary tumor too in a young man. So that while two medications might be used in a temporizing mode, I would think that other than ketoconazole, the medicines are all very costly, and you have to give a lot of credence for whether that's a good long-term plan.
Yes, I agree with that. In fact, after the second surgery, he underwent the radiotherapy with a CyberKnife. That's what he's been through now. So, because
I would have done.
Yeah, that's what he's going through right now, and certainly it is a challenge, and there are several issues, quality of life, and other things. So certainly, so thank you, Dr. Winters. So there's a question in the chat. Thank you for the comprehensive. How effective is pituitary surgery in retaining normal pituitary function, or is the gland removed along with the tumor requiring supplementation? So the answer to that is when you have a very excellent pituitary center and a great surgeon, usually, depending on the extent of the tumor, this tumor that we saw is unusual. It was large. There was extension, so it was hard to remove it and not have some pituitary function loss. But sometimes that could be achieved with intact pituitary function. So, yeah, it depends on how big the tumor is, how the skill of the surgeon, and a lot of different issues. But certainly preserving function is their goal also when the surgeon goes in. So, Dr. Winters, did you have any comments to that?
No, I agree with you.
Okay. Any other questions from fellows or Dr. Mokshigandam? No. Okay. Well, thank you very much. Dr. Winters, do you have any other comments or questions?
Well, just for the fellows, when you showed all the genes associated with Cushing's, the thing to remember is what they call this TPIT, the transcription factor. So TPIT is a transcription factor which leads from a pituitary stem cell to a ACTH producing cell. And you can categorize an ACTH tumor, which sometimes don't stain very well, as Cushing's based on these genes. So it's very hard to remember all those genes which are implicated in tumorigenesis, but I think it is important to remember TPIT.
TPIT, yeah, which is, I think his staining was positive for that, so.
Yes.
Yeah. He had
TPIT.
Yes. Hi, Swapna.
Yeah, hi, wonderful talk as usual, loved it.
Thank you.
Just one quick question. Based on the pathology of the initial tumor, whether it's phenotyping or, whether there's mutations that you can, is there any guidance to treatment changes or medications?
So that's actually a very good question that you asked, because I did forget to mention the the USP8, USP48, those mutations, apparently they do respond very well to pasireotide because of the somatostatin, whatever the mutation. So that is at least one factor that I recognize, but I'm not, I may not, I mean, I read a lot, but right now it doesn't, I can't think of other things that may be responding, but Dr. Winters may have answers to that. So, but certainly this one, it said it responds very well to pasireotide or cabergoline, just because of the
thank you.
pathway. Yeah, yeah. Okay. Any other questions? Okay.
Dr. Winters, did you have any more information on that, or is the pathology report pretty standardized in terms of giving us all this information? Or does it just say ACTH staining tumor, or does it depend on the facility?
What I think the report is going to vary by pathologist, really. I mean, you know, some pathologists are a lot more eloquent and verbal in what they tell you, and others are very succinct. And I don't think there are any generalizations. Generally, you will see both the staining for the transcription factor nowadays, as well as for the hormone, and they will talk about being densely stained or granular formed. And those are the common terms that you might see in a pituitary pathology report. I think it's, you know, I mean, most often the pathology confirms what you know clinically. Satya knew this man had Cushing's syndrome. There was almost nothing that she was going to learn from that pathology report other than this issue, that important issue that she brought up about the potential of recognizing pasireotide responsive tumors. I can't say that I know that paper chapter and verse, and I don't know really how potent the impact of the mutation is on the response to that drug. I'd have to look that up. But that's an important point. It's very novel.
Thank you. Thanks a lot.
Okay. Any other questions? Good to see you, Dr. Winters.
My pleasure. How's your family?
Everybody is good. Everyone is good. Okay.
I'm glad. Have a nice day.
You too. Thank you.